All right. Well, everyone, it is a pleasure to welcome you this morning to one of our outstanding speakers who's going to provide a plenary talk, Dr. Liz Berry-Kravis. Dr. Berry-Kravis is extremely well known to everyone, especially within the Fragile X world. She's a professor of pediatrics, neurological sciences, and biochem at Rush University in lovely, frigid Chicago. As stated, I mean, she's really one of the world's foremost leaders in Fragile X, and has established a clinic that's been running since the early 90s that's currently treats about 700 plus patients. Beyond that work and expertise, she's conducted innovative work in multiple other areas of different genetic and developmental disorders. She's one of the cool things beyond kind of the expertise in science and the prolific publication, presentation, grant record is just the engagement with stakeholders. And I think we can even, by viewing her office, kind of see some of that behind in a great way. The final piece I'll say is, again, I mean, prolific author, prolific scientist, but also a gifted and warm clinician and mentor. Who's really had an impressive impact and significant impact on the field. So without further ado, I'm very excited to introduce Dr. Berry-Kravis and get off the screen and leave the show. So thank you.
Okay, thanks, Eric, for that really nice introduction. And I'm gonna go ahead and share my screen, which is hopefully gonna work. Okay, share. Okay, so hopefully you can all see my screen now. And we'll start from the beginning. Okay, so I'm going to talk about Fragile X syndrome today, a topic that's been near and dear to my heart for over the past 30 years. And I'm going to try to go through a discussion of the treatment advances in Fragile X. So the first part of the talk, we're going to talk about what Fragile X is, and then we're going to talk a little bit about how we've worked to improve our understanding of Fragile X and supportive care in the field. And then we'll talk about novel interventions and disease target therapy and what we've learned in our trajectory of 18 years of clinical trials to try to target the underlying disease in Fragile X. So it'll be a lot, but hopefully it'll be informative. And I'm really glad to be presenting at the Gatlinburg conference. As you can see, originally I was thinking we were going to San Antonio, I think, but that got morphed into this internet conference, which of course none of us love as much as the meeting. But so far it looks like it's serving our needs, and hopefully we'll all be together at meetings next year. Okay. So I'm just going to pull some of this stuff in. So actually, I'm going to tell you how I got involved in the Fragile X field. I'm just going to have everything on the slide here. I initially studied Fragile X just because of an interest of Peter Huttenlocher and Eric Kandel. Peter knew Eric well, and Peter was my training director at University of Chicago when I was a fellow in pediatric neurology. And they were very interested in the cyclic AMP signal transduction pathway because Eric had studied it in Aplysia. And there were these mutants in flies that had high and low cyclic AMP called Dunce and Rutabaga that had impaired learning. And so they wanted to study a condition called pseudohypoparathyroidism, which has a defect in the cyclic AMP signaling cascade. And we needed a control group. And the control group, the only control group we had enough patients in that had a consistent same disease was Fragile X syndrome. So we were studying them as our intellectual disability control. And it turned out the patients with Fragile X had a bigger defect in cyclic AMP than the patients with pseudohypoparathyroidism. And this is actually the first study in Fragile X I did, where I showed that when you stimulated cells with either prostaglandin E1 or forskolin, which activate cyclic AMP, the Fragile X patients did not activate cyclic AMP nearly as well as the controls, and we had dose responses. And then we published this paper, and this is not a baby with Fragile X. This is actually my second child, born in October of 1990, literally 5 days after I got, well, literally 5 days before I got these results and went to the Child Neurology Society to present them. And so he marks really my first presentation on Fragile X syndrome, his birth. And so keep cyclic AMP in mind, because this is going to come back to us toward the end of the talk. There was really no way to target that mechanism at the time, because actually when I first got the cyclic AMP results, the gene for Fragile X wasn't even known, but subsequently it was discovered right after I initially presented those results in 1991, and of course was found to be FMR1. And after finding FMR1, we started to understand a lot about the genetics of Fragile X syndrome. We know that FMR1 has these CGG repeats at the beginning of the gene, and normal people have like 10 to 45 of these, and they're translated into the FMR1 RNA, and they make the FMR protein, but they're not in the translated portion of this. So they're transcribed into RNA, but not translated into the protein. So it doesn't matter if you have 10 or 45 CGGs, your FMRP is all the same. So patients with Fragile X syndrome have this big mutation where they have more than 200 of these CGG repeats that causes the gene to be methylated and shut down. It does not make FMR1 RNA, or it makes less FMR1 RNA, because sometimes it's not completely shut down. And there's no or reduced amounts of FMRP, and synaptic deficits and intellectual compromise because of the lack of FMRP. Now, you can also have a deletion in FMR1 or other mutations, and those have the same result, that FMR1 is not functional. So now we know that about 1 in 4,000 males and females have Fragile X syndrome. It's the most common known inherited cause of intellectual disability and the most common known genetic cause of autism spectrum disorder. And we have a simple DNA test where we can identify both the size of the mutation and the methylation of the mutation. So what does FMRP do? Well, so Fragile X results from the lack or reduction of FMRP in the brain. And FMRP, we now know through really, this is kind of decades of research. FMRP sits in an RNA binding complex, which associates with ribosomes that are out here on the tips of dendritic spines where neurons connect. And so it regulates the activation of these neurons based on the amount of activity going on in the synapse. It regulates, and it does that by regulating dendritic translation, or the translation of other proteins that are typically activated when the neural cell is activated. And it works through signaling in association with FMRP is through multiple signaling pathways. The result of that aberrant signaling because of the absence of FMRP gives us abnormal looking dendritic spines. So this is the Fragile X mouse, which has these nice short stubby spines that are the mature spines. And this is the FMR1 knockout that has these long spindly spines that are not the mature spines. So when there's no FMRP, we have morphologic immaturity of the spines in the brain. And this you can also see in human Fragile X brain compared to controls. And there's also electrophysiologic abnormalities that go along with those morphologic defects, such as this exaggerated long-term depression, this exaggerated mGlu-R regulated long-term depression in the hippocampus of the Fragile X mouse. And there also are abnormalities of long-term potentiation, and this varies by region and neuron type in the brain. So this is a complex disease that impacts different parts of the brain, potentially even differently. And as a result, we have a complex and variable disorder in terms of severity and manifestations. So patients with Fragile X typically will present with developmental delays, most commonly speech delay, but sometimes even earlier with motor delay. And they have features that I've kind of put into 4 domains. They have physical features, and this child shows many of the physical features, like large ears, a long face, large testes, and flexible joints. But these physical and facial features are not consistently seen in Fragile X, and you can have patients who really don't have these features. There are some medical problems that we now know are associated with Fragile X, like seizures and otitis media. I'm going to talk about those more in a minute. These are mostly manageable. They create a ruckus for some patients, but by and large, they are not nearly as problematic as the cognitive and behavioral difficulties that we see in the condition. So patients with Fragile X have a low IQ. They have problems with adaptive, social, and language deficits, and that's all cognitive deficit. And then they have problems with behavior, like distractibility, hyperactivity, anxiety, aggression, perseveration, many behaviors that overlap autism spectrum disorder, but can also be different. So these cognitive deficits are the core deficit. They result from the neuronal connectivity and plasticity deficits due to absence of FMRP. Behavior comes from the neuronal deficits, but also can be created by the cognitive deficits because of patients not knowing how to respond to something in their environment appropriately. The cognitive deficits result in developmental and learning delays, impaired independent functioning, inability to support oneself, and impaired quality of life. The behavior deficits are highly variable from person to person in the amount, severity, and type, but also limit community access, vocational housing, and social options, can result in injury to caregivers and impaired quality of life. And these two problems bounce off each other in that if your cognitive deficits are larger, your behaviors tend to be more immature and problematic. And if your behavior deficits are large, even if you have good cognition, you can't function well in society. So the current treatment of Fragile X syndrome is essentially supportive treatment, where we push early intervention, try to get kids into intensive therapy like speech therapy and OT, push for inclusion because the kids are good imitators. And then we have a whole list of things we try to do with the educational curriculum to match it to the cognitive profile of people with Fragile X, socialization programs, behavior plans, behavior medications if behavioral symptoms are limiting for the patient, and then managing the medical problems so that they don't interfere additionally with the patient's development, like managing otitis media, sleep apnea, checking for vision problems, controlling seizures, doing orthopedics like for SMOs for flat feet if needed, managing sleep, and of course genetic counseling and reproductive options, which is a huge issue in an inherited genetic disease. We've had individual clinics for Fragile X patients for quite some time. Ours started in 1992, but in around 2004, we decided we needed a network of clinics to really accomplish this list of goals, to provide patients access to care so they didn't have to travel halfway across the country to get care at a Fragile X center, to standardize care delivery, which we've been doing with by creating consensus documents for various problems in Fragile X, to increase research cohort size, so we weren't just looking at 20 patient studies done at one site, to collect natural history, and we have had a natural history project called Forward that's been funded by the CDC since 2009, and to form a clinical trial network for ultimate clinical trials in Fragile X. And so this is the current FXCRC, or Fragile X Clinical and Research Consortium. And these kind of magenta clinics are all the 26 clinics that are actually participating in the Forward project. There's 6 clinics that were participating in Forward but aren't anymore, but are still clinical sites for Fragile X. And then there are 2 clinics that don't participate in the project but are clinical sites seeing patients. And there's a couple of gray clinics that have actually left the FXCRC. So you can see this is a fluid organization, but we currently have 34 clinics involved in the FXCRC across the country. So this is the consensus documents. They're listed as recommendation documents on the National Fragile X Foundation website. And this is just a snapshot of the website where families can go and pull down these documents. And so we started doing these documents around 2012 or so. So a lot of the early ones were published then. We are gradually updating these. And so you can see the updated bar and when the consensus document was updated. And originally these were based almost entirely on expert consensus, with some pulling in some clinical data from the literature. We're now updating these with actual data that we're getting from Forward on the actual frequency and types of problems that we're seeing in Fragile X, and what that has informed us in terms of the management of Fragile X. So this has been a great product, and it's a very useful resource for families. And for other physicians trying to manage people with Fragile X if the patient can't get to a Fragile X clinic. So I'm just going to run through some of the studies that we've done in Forward, because there really is a lot of work that's come out of Forward. This was the initial study. And as you look at the ends, as these slides go on, you'll see the size of the cohort gradually go up. And that's because I'm going kind of from earlier studies to later studies as the database got bigger and bigger and we had more patients in it. And the patients are enrolled at all those clinics I showed you. So we had the initial paper out of this out of the pilot database that was from 2009 to 2011 was on 260 Fragile X patients, and really just looked at the frequency of medical problems. And what we found was that seizures, the blue is Fragile X, the red is the population. What we found is that seizures, frequent ear infections in childhood, and strabismus were very significantly, and loose stools and sleep apnea were very significantly increased over reported rates in the general population. Sleep problems a little bit elevated, tics not really. Mitral valve prolapse we didn't find often, and there was some increase in gastroesophageal reflux as well. So this gave us information that allows us to provide anticipatory guidance for physicians and families about problems that we should ask about and screen for in clinic. And we do indeed ask about all of these problems within the Forward project. And then this initial article, as well as ongoing articles, provide recommendations regarding treatment and management for these kinds of problems in Fragile X syndrome. We had a recent paper that came out on toileting in Fragile X. One of the most common questions that families would ask me in clinic years ago would be, when will my child toilet train? When is he ready? When should I start him? Well, so this is toilet training in Fragile X out of Forward. And this was published in 2019. But what we found was these are survival curves for toilet training. So as you can see, most kids with Fragile X, sort of half of them are toilet trained by 5, and most do toilet train. The kids with Fragile X and comorbid autism, the boys are far less likely to toilet train quickly, and even out at age 15 or so, we've only got 75% of them toilet trained. And the girls toilet train as would be expected, because girls are less affected with Fragile X due to their normal X chromosome. They toilet train more on a normal time frame. So that when we do a multivariate analysis of what factor causes toileting delays, they are most driven by the patient's level of language, and secondly by autism status, and then somewhat by irritable behaviors. So this allows us to provide guidance again for physicians and families about when to expect to initiate toilet training. If your kid is 2 and they have no interest in toilet training and don't seem to understand it, we don't suggest toilet training. But when they're 5 and getting ready to go to school, this is kind of when kids train. So for children in the risk group with ASD or severe language impairments, we know now that we need to reset the expectations of the family and adjust the process of training to more of a time training method and expect a prolonged trajectory. So you don't give up. You have to keep persisting for multiple years sometimes to get that training, or you're going to fall into this category that's not trained as an adult. Autism spectrum disorder and Fragile X syndrome. So we, at the time when the database was 547 individuals, we had 42% who met criteria for autism spectrum disorder based on DSM criteria, 51% of the males and 18% of the females. And what we could see, some of the variables that came out of the database as most associated with autism were seizures are higher in patients who have comorbid autistic spectrum disorder, as are sleep problems, as is aggression and irritability. And so there's a marked increase also in the frequency of hyperactivity and sensory hypersensitivity in those who also have autism spectrum disorder, and increased use of antipsychotic drugs and alpha agonists. And another thing we discovered was only about 20% of kids with Fragile X and autism spectrum disorder were getting ABA, while 36% based on literature at the time of kids with idiopathic autism spectrum disorder were getting ABA. So this led us to be able to observe and look for kids with comorbid autistic spectrum disorder, so that we could manage these kinds of risks that are associated with autism and Fragile X. Anticipate the sleep problems and behavior problems that may be less likely to resolve with age if the child also has autism, and you may have a lower threshold to start medication if you suspect this is going to be an ongoing disruptive problem. And then it allowed us to know that we need to advocate for behavioral therapy and modified ABA in kids with Fragile X, and need to find ways of being sure the insurance company understands their Fragile X syndrome is autism and not something different, so they don't deny it. We've studied irritability, agitation, aggression, and SIBs, and this is the psychiatrists call this IAAS in Forward, because this is probably the most disruptive behavior problem that you can have in a family. And this problem occurs in about 50% of individuals with Fragile X syndrome and is a limiting problem in 67% of those 50%. And so when we look at patients who need medication for this type of behavior, and we have 235 on medication and then 180 who are 235 not on medication, then 180 who are on medication. These red people who need medication for this type of behavior are older, have a lower IQ, are more likely to be male, have more likely to have seizures, again, probably because of the autism relationship, are more likely to have autism, and are more likely to have limiting anxiety. And Risperdal and Abilify account for the majority of medications used to manage this problem. There are no side effects apparent in about 62%. The most common side effect is weight gain. So again, this helps us understand the behaviors we're seeing, provide guidance to families, and monitor closely patients for weight gain, and then manage that weight gain if needed. This is a study that we're doing currently that's in preparation on sensory hypersensitivity, sensory issues in Fragile X syndrome. And so in Forward, about 73% of males and 54% of females have this problem, and it's limiting in about 48% of males and 36% of females, meaning the person can't go in the community or can't do something as well because they have too much sensory issues. And so you can see the yellow line here, sound sensitivity is the most common issue, both in males and females with Fragile X. And this is difficulty with eye gaze, which increases as we get older, and we see that in our Fragile X populations. And then touch sensitivity is relatively common, and sensitivity to bright lights and gravitational insecurity less common. One of the things that we see as we track how are people treating their sensory problems over time is that we can see that all the therapies come down and the medications go up. And this is because people don't have access to therapies anymore, and because sensory problems can evoke aggression, and when patients get big, that's a big problem, and so then they're more likely to be treated with medication. And so this means that we need to have awareness of these issues for the school program and plan things like pre-planning of fire drills and things like that, and therapy planning, and ask teachers not to force eye contact because that'll be disruptive. We need OT to manage these sensory problems, and we need to find ways to have therapy programs in adolescent and adult life, which is a problem not just for sensory therapies, but for therapy in general. Sleep problems. Sleep problems are common in Fragile X and much more common in younger kids with Fragile X. And these include things like trouble falling asleep, refusing to go to bed, frequent night awakenings, being tired in the morning. And then we have a category of grinding, things that wake you up at night, like grinding your teeth, wetting the bed, and being restless. And then snoring, which is a bit of a separate problem from some of these other sleep issues. 83% of patients with Fragile X had any sleep problem. There was at least one type of problem that was moderate to severe in about 40% of patients. And this was a problem for the family in about 20%. So not all sleep problems are a problem. All the sleep problems, if they were more severe, were more likely to be associated with limiting hyperactivity and IAAS. And these problems did tend to decrease in age, especially the struggle at bedtime, except for snoring increased with age. And there's an interesting disconnect that we have in Forward where families report mild snoring at about 70% and moderate snoring at about almost 20%, severe snoring, a little over 10%. And there are very few, there's only 3% clinician diagnoses of sleep apnea. So it's really possible that we're underdiagnosing this in clinic. And so this produces an awareness of sleep as a problem for a significant minority of families with Fragile X, allows us to set expectations regarding behavioral associations when people are having sleep problems, and to try to fix sleep, maybe to get rid of behavioral problems. And sleep apnea may be more common than we thought in Fragile X and maybe underdiagnosed, and clinicians need to be aware of this and get testing when needed. Testing can be very difficult to get from these patients, and that may be one limiting feature behind behind making these diagnoses. Okay, so cognition in Fragile X. Now I'm leaving the Forward database a little bit here. This data is not from Forward, but this is the recent effort that we've had to really understand what is IQ in Fragile X. And so David Hessel developed the z-deviation method of finding an IQ so that everyone's IQ is not just stuck at 40 at the bottom of the Stanford Binet IQ test. And this really has revolutionized the thinking about intelligence in Fragile X and even other developmental disabilities. So this is our first study with the z-deviation IQ with 372 people with Fragile X. And you can see the range is huge. There are patients with an IQ of almost 0 and patients with an IQ of up to 90. And you just you don't see this kind of effect. You don't see the real IQs of under 40 when you use the standard IQ method. And David's method is now on the Stanford Binet website as a way of looking at the way you should look at IQ in intellectual disability. And then the girls, of course, have a higher IQ. Now we have a bell curve for Fragile X. Before, most studies, the IQ in Fragile X looked like this. And how are you going to make any correlations with anything when you have a curve like this? And a huge percent of your sample is just sitting at 40. You're not differentiating who has problems and who doesn't. And now this is going to allow us to look at people's actual cognitive functioning and correlate it with outcomes we have in Forward, like when you grow up, these are actual adult outcomes in Forward. And this is the percentage of patients with no vocational activity, people who are in a day program, people with some supported employment, people who are in employment without support. And we're going to be able to look at relationships, for instance, between cognition and where you go over the long term in terms of functionality. So there is a characteristic cognitive pattern in Fragile X, and this list is based on a lot of researchers in the Fragile X field, and comes from this abnormal brain connectivity shown nicely here in one of Alan Reese's papers, where normal girls doing mental arithmetic are activating all these areas of the brain, and Fragile X girls are activating these little areas of the brain, and this is where we have this kind of cognitive problem. But we also have a pattern of strengths and weaknesses, where strengths are things like receptive vocabulary, syntax, imitation, grammatical structure, visual memory, and kind of experiential and simultaneous learning, whereas weaknesses are auditory processing, sequencing A to B to C, abstraction, short-term memory, staying on task, math, working memory, and coordination. And we can actually see these strengths and weaknesses better using z-deviation IQ subscores, because we're not just flooring out at 40. So we can really see the different patterns and hopefully use that for educational planning. And so knowing this pattern allows us to give the school ideas about how would you manage this person's program, for instance, using more visual learning and having picture schedules and token boards, more simultaneous processing, put them in settings where they can imitate things and sort of do real life experiential learning, and put in ways of minimizing the attention problems and the distractibility, help with task initiation, do less sequential processing, which means less phonics and more visually based reading, for instance, computer-based writing, so they can type instead of writing, and then managing the anxiety and the behaviors, as well as their problems with novelty. So a lot of good ideas we can get from the cognitive profile on how to make the patient more functional and learn better at school. This is some data from a sub-project we have of the Forward project, which is called Component C, and just ran at Denver, Rush, and Cincinnati. And we collected data on specific measures to really look at how these would perform longitudinally over time in Fragile X, with the idea that eventually we'll have treatments that modify the disease, and we can look at we can compare some of this data, for instance, to patients on long-term treatment. So this is just baseline data, because we haven't analyzed the longitudinal data yet. But one of the things we were able to do is look at the repetitive behavior scale and pull out the things like hand and finger stereotypies, preoccupation with one subject in activity, and resistance to change, that are the big problems in the repetitive behavior domain for people with Fragile X. We've been able to look at the cognition and replicate some of the data that David Hessel has from the combined series that I just showed you. And again, it shows that over time, both studies show that over time, the IQ goes down in Fragile X, and that isn't because patients aren't developing, it's just because they're not keeping pace with a typical rate of development in in normal peers. But this is very important to know, because if we do a study and we just stabilize the IQ in kids, that means that we would be doing really well because it's not going down. And that's an important point to know for long-term clinical trials. This is language. We studied the self in Fragile X. You can see they're all different groups. This was Ann Hoffman's work. She had to group the patients into females and males in all different groups based on what type of testing she did with the self. And this just shows us how typical language testing is a big problem in a disease of variable cognition, because you don't have a one-size-fits-all test that you can really give everyone. But if you convert this to sort of age equivalencies, then what you can see is that patients with Fragile X have, in language, they have a similar pattern to cognition, where many patients kind of tail off in terms of their development, but some don't because they're just higher functioning. So this is the kind of information that we're going to be able to get from this longitudinal study when we have everything fully analyzed. Behavior. So behavior is a huge problem in Fragile X, and I actually just queried the forward database, and we were now up to 1,626 participants with a lot of visits. And this is actually looking over time at longitudinal visits at the 3,593 visits we have in forward. So I did this for the recent PFDD we had for Fragile X at FDA to show the problem of behavior and the fact that behavior is not in one category. So we can't just have outcome measures that just look at one category, because look at this. We have behavior distributed across attention problems, hyperactivity, sensory problems, anxiety, perseverative behavior, not as much mood and depression, but some of that, and then irritability and aggression. And anxiety, though, is the #1 problem. When is behavior treated with medications? Well, in many of the patients where it's a limiting problem. And so again, anxiety is the problem most commonly treated with medications in people with Fragile X. But again, there's a variety of different behaviors, and it's not just one behavior that's problematic. So then I asked the question, well, how many people just have one? Like, are there people with just anxiety and just hyperactivity, or are all of these patients showing multiple limiting types of behavior? And in fact, 23% of patients in forward have no limiting behaviors. 12% have that one type of behavior that's really their problem. 65% have multiple types of limiting behaviors, and some of them up to 7 different types of limiting behaviors. So when we're looking at this from a standpoint of a clinical trial, we can't be picking the one behavior, because these are all linked with each other in the patients. And we really have to individualize approaches. 38% are on no medications for behavior, 11% are on a medication targeting one behavior, and 51%, half the patients in forward, are on medications for multiple types of behavior. And so this tells us the need to be able to really measure multiple behaviors when we're assessing outcomes. So what do we use what kind of medication do we use for patients with Fragile X? Well, the same things that we do for any other developmental disorder or ADHD, for instance, or in autism. We use stimulants for attention problems. We use alpha agonists like clonidine and guanfacine for overarousal, hypersensitivity, hyperactivity. We use SSRIs most commonly for anxiety, although really we use all different anxiety medications as well. We use sometimes tricyclics or mood stabilizers for mood lability, and then for aggression, most commonly Risperdal and Abilify, but also other antipsychotics. Some of these meds may be targeting several behavioral clusters. And when we look at what happens over time, what happens relative to time to age in Fragile X, medication use for behavior increases with age to adulthood. And that was some of what you were seeing on that slide with the that was looking at sensory management. We have a lower percentage of females on medication at all ages. That's to be expected. The behaviors are milder. And then as we go from borderline intelligence to severe intelligence, what we can see is that, #1, there's an increase in medication use, and there's an increase in use of antipsychotics and alpha agonists, because those tend to manage more of those very difficult irritability and aggressive type behaviors. So do our medicines work? Well, that's a question that's been a little hard to get at. We only have one controlled trial that Rondi ran back in like 1985 that shows that stimulants do seem to improve attention. This was a placebo-controlled trial on about 15 patients. But the rest of our data has been data from clinic where we just ask, well, is the patient doing well on this? Is their response extended for 6 months? Is it being reported by both family members and school? And so clinical assessment. So if you use clinical assessment like that, and you use, for instance, one stimulant for attention, you get a response in a little over 50%. If you try multiple different stimulants and try to find the right one, you can get clinical responses of up to 70%. There's, of course, a fair amount of placebo buried in this. For anxiety, the same thing. You get about a 50% response with one medication. If you try different things, you can get almost up to 80%. Same thing with antipsychotics for aggression and irritability. You can get a response in over 70%. And alpha agonists, about 60%. But if we ask the families as a group, how well are those medications working? This is a survey that Don Bailey did, and I analyzed with him based on our Fragile X World survey. And so the families will tell you the medicines are working a lot in about 30% of cases, shown in green here, somewhat in these red patients, and a little or not really at all in the blue patients. And it turns out when we look at these different kinds of things we treat, the only thing we're really good at treating is seizures, and that's because those are relatively easy to control in Fragile X. So there's clearly an unmet need for better behavioral treatments and for any kind of cognitive treatments that we could find. And we need to have more effective supportive medications as well as treating the underlying disorder. So we did a voice of the patient to ask families, if we had new drugs, what would you really want to be what would you want us to be targeting? And so first of all, we asked, what are your biggest concern? And so behavior for males is the biggest concern out until adulthood, when cognition becomes as big a concern. But intelligence is the second biggest concern throughout all age groups. Females, behavior is a big concern early on, but cognition becomes the bigger concern in all of the age groups over 6, and that's because behavior isn't as much of a problem in general in the girls with Fragile X. And then when we ask families, if we could develop a drug, what should be our #1 treatment priority? We get anxiety as the highest treatment priority and learning as the second highest, and then general behavior. And communication tends to be something that the families of the youngest children endorse a lot. So this is the priority of drug treatment. And so clearly we have our work cut out for us, and we have this information in front of us to talk to organizations like the FDA when we're trying to develop a new medication for Fragile X. So with that, I'm going to move on to looking a little bit at clinical trials that we've done in Fragile X, and try to run through that fairly quickly. So we have a lot of treatment targets that we've had. We have this mechanism that's been proposed that's called the mGluR theory, where glutamate stimulates the mGluR5 receptor, and glutamate is everywhere in the brain. And you kick FMRP off the ribosome normally and activate this protein synthesis. But in Fragile X, there's no FMRP, so you've got over signaling through this cascade all the time, and that creates numerous different molecular problems. And this is just to show you the amount of work that's gone on in Fragile X. So you could theoretically correct this pathway in Fragile X with mGluR5 blockers, with agents that block down this signaling cascade, and there's a big list of them here, with drugs that work on a specific protein, with things that activate AMPA receptors that are reduced in Fragile X, things that adjust GABA functioning, which is abnormal in Fragile X and which affects the amount of glutamate in the synapse, microRNAs to reduce some of these key proteins that are being overproduced, and channel blockers, because FMRP regulates some channel blockers directly. Believe it or not, treatments aimed at all of these things have reversed phenotypes in the Fragile X mouse model, and many have been used in early human trials in Fragile X. And in fact, these are all things that have been used in early human trials, and these are the big arrows are things that got to a phase 2-3 trial, And the other red arrows are things that were in a little trial and now development is stopped because either they didn't work or there was no development path forward. And then the green arrows are things that are still being studied right now. So we've gotten that to include as well, including CBD. So we have a lot of work going on in trials in the Fragile X field. And there have been concerns about trials that have failed in the past. So one of the big trials that failed was the arbaclofen trials, which many families with Fragile X are very familiar with. The FDA forced us into one outcome, one specific report measure that we had to, that had to be the primary outcome, which was one section of the aberrant behavior checklist that measures some of those problem behaviors in Fragile X. So we did a phase 2 trial, and what we saw was that we saw a trend toward improvement in many different measures, not in the thing that we said we would measure as the primary outcome, which was irritability, but we saw improvement in the CGI, which is a clinician rating of how the patient does, in the treatment preference, in visual analog scales of the 3 worst behaviors the Fragile X patient has, and that was the most significant improvement. And then when we refactored the aberrant behavior checklist for Fragile X, we saw an improvement in the social avoidance scale. So we went back and we said, okay, let's run a phase 3 trial, but let's make social avoidance our primary outcome. So Seaside ran 2 phase 3 trials. There was no efficacy in the older age group. In the younger age group, the trial was stopped early because Seaside ran out of money. And it turned out that even with a smaller than expected sample size, ABC irritability was significantly improved in this trial, and parenting stress was significantly improved corresponding to that, because parents are going to be less stressed if their kids are less irritable. And we almost achieved statistical significance for social avoidance and hyperactivity, but by that time Seaside was out of business, so that study never went to the FDA. The effect size in this study, in this 5 to 11-year-old study, was as good as any of the approved SSRIs. And if we looked at patients for a year of treatment after they went into an open label extension and looked at the Vineland Adaptive Behavior Scale, normally the Vineland would go down over time, shown in the red line from natural history, but it actually was stabilizing or going up in the Seaside trial. So we need more data than 30 patients to look at that, but we are working on getting that data from the Simons Foundation. So why did this trial fail? The drug clearly worked in some people. There was a subgroup effect, and not everyone responded. We were using the same inclusion measure as the primary outcome, so families gamed their entry and rated things higher to get in the study, and then regressed to the mean. So we had big placebo effects. The outcomes did not pick up all the areas of benefit. The visual analog scale for specific behaviors we used in the phase 2 trial was much better than the general category of behaviors. And so some of the FDA precedents, like using fixed doses and the one behavior, were really problems. And then the company had commercial problems. So the other group of drugs that went to big trials in Fragile X were the mGluR5 blockers. And so this is the model with the most preclinical data. And this is just a giant list of mouse phenotypes that have been reversed in this condition, including things like audiogenic seizures, epileptiform bursts, dendritic spine morphology measurements. And so there were over 50 papers from over 20 labs showing pharmacological reversal of 90% of mouse phenotypes by mGluR5 blockers. This is a very large body of support. And then phenotypes in the Fragile X fly were also reversed. And then phenotypes were reversed genetically by crossing the FMR1 knockout mouse to the mGluR5 heterozygous mutant that has less mGluR5 receptors. And you could still get reversal, and then phenotypes in the rat were reversed. And this led one of my patients in clinic, the dad of one of my patients in clinic, to say it's a great time to be a Fragile X mouse. And indeed, it is a great time to be a Fragile X mouse. But we are trying to get this translated to humans. When we went into humans, we had an early phase 1b trial that showed normalization of pre-pulse inhibition over test-retest controls. It looked like we had target engagement. And then we ran some big studies with Roche and Novartis. This is the Novartis drug. This is actually the ABC, so lower is better. This is the placebo group. They did the best. But look, when they were in the placebo run-in, when everyone was getting placebo in this first 4 weeks of the trial, they were still doing the best then too. So this is just a very suggestible group of people, and the placebo is here. And so this drug didn't really work for behavior. in adults or adolescents with Fragile X. It didn't work with the Roche drug either, and they were measuring anxiety and other behaviors on the atoms. And so the Roche and Novartis programs were disbanded. But when we did a sub-study with UC Davis, we did show improvement in fixation to the eye region in eye tracking, as well as an improvement in the KITAP, which is a cognitive test that we had worked on standardizing for Fragile X syndrome, with better correct answers on the go, no go test. So the patients were less impulsive, and they seemed to be able to do this test better. So the question is, why did these trials, what went wrong? How did all that preclinical data in 3 species with 4 drugs and genetic and pharmacological correction not lead to registration? Well, we think there are a lot of issues. We think maybe we were looking at the wrong outcome target. We were using, again, the FDA precedent of the behavior checklist, measuring behavior instead of cognitive function. The questionnaires have high variability and were being employed in like 20 different countries and multiple different languages. And we were maybe at the wrong age to see cognitive change. We should have been looking at kids. We probably need a longer trial. Maybe we need a learning intervention, and maybe the mouse trial is just not predictive. So new treatment development in Fragile X took a turn after these big failures, and we began to understand we need to treat the whole disorder and assess the impact of treatments being developed on all of the disorder. We need to be able to assess observable behaviors families see when they identify anxiety. We need composite measures that take into account improvements in multiple behavior domains. Because these patients are very different from one patient to another. We need to be able to find treatments for cognition and have a way to assess cognitive function. We need to be able to look at kids in early trials, because disease-modifying treatments are likely to work better if you use them early. So one of the things we did was we created a clinical trials committee, which was created to try to prevent repeats of these large failed trials. And we work with companies on trial design, outcome measures, the development path, try to get more stringent animal work before we go to humans. And so we're trying to make a more rigorous development path early on and do early studies where we can look for PK/PD to determine whether the drug is having an impact on the brain in Fragile X. And we help with what kind of outcomes to target depending on what the drug is. And we'd like to have a discussion with the FXCRC, the Clinical Trials Committee, before the National Fragile X Foundation endorses new trials in Fragile X. So one of the other things is that we thought we might need to measure learning in a trial, but we might need to push learning and embed a learning intervention in a trial. So that means we need a specific learning intervention that works in Fragile X syndrome. And so Len Abaduto has developed a parent-implemented language intervention that's delivered by Skype and has been shown to improve vocabulary learning in individuals with Fragile X. And David Hessel's been working on CogMed, which is executive function training, computer task, and has shown that Fragile X patients can respond to that. And so the PILI, the language intervention, was tested in a single study with lovastatin and placebo at UC Davis that showed that PILI works really well, but lovastatin doesn't work all that well. And then in our multi-site NeuroNext trial that's run by me, and so the idea of this trial was to say, hey, we did all the mGluR5 blockers trials wrong. Now we're going to try to do it right and correct everything so that we can really know if the mGluR5 mechanism is something that we can target in Fragile X. So in order to explore this, we have funding from the NIH through the NeuroNext network and from a Novartis investigator-initiated trials program that I have a grant for the drug for. So in this trial, we've been studying kids who are 3 to 6 years old. We created a long trial to study learning, embedded a language learning intervention to amplify and focus the learning on one type of language learning. And then we have objective language and cognition measures, as well as an observational communication measure. The weighted communication scale is our primary outcome. So this is targeted to measure the type of language learning that we get from PILI during the study. Then we have biomarkers as well. This is the first ever large multi-site trial studying the effects of a targeted drug treatment on learning. This is the design of the trial. We have a blinded treatment period where patients are randomized to drug or placebo. The final 6 months of that, they get the language intervention, and then they all have an opportunity for open label treatment. The design allows us to take the placebo group and look at the effects of initially just nothing, and then the language intervention, and then the drug plus the language intervention, so we can look longitudinally as well as across the as well as across the groups. The primary outcomes are at the end of this blinded treatment period with either AFQ-056, the mGlu5 blocker from Novartis, or placebo. So we have now completed enrollment in that trial. We enrolled 110 patients, randomized 99, and have 91 that got all the way through this trial, even despite COVID, which is a huge accomplishment. These were our trial sites and the inclusion criteria for the trial. I'm not going to read off this whole slide, but we did a huge amount of training and created process for multi-site standardization methods that we can use in future Fragile X and neurodevelopmental disability trials, including standardization of our biomarkers like ERP and eye tracking, ways of monitoring medical and therapy history, standardized the clinician global impression scales, standardization of the delivery of PILI, as well as these weighted communication scales and all the different site administrators. These are all the people we trained to be on during this study, which is, again, a huge undertaking. So we got hit by COVID-19 in the middle of this study and implemented remote visit process for all but 4 essential visits to accommodate the pandemic within about a week of the pandemic hitting, because we were very aggressive to get this in place so we wouldn't miss study visits. We have a new remote weighted communication scale administered by our remote weighted communication team, which has actually worked pretty well. And then our SLP team, really went off the wave and took us above and beyond the study for COVID-19, because our central SLP team that delivers the speech language intervention to the study participants was recruited by multiple states to give talks to therapists and early childhood educators on how to do remote language intervention. And some of the families consented for use of their videos for the central SLP team to train the world during COVID-19. And they're creating web-based learning modules and manuals and talking at video conferences. And so we have done, hopefully, our part in the study to help with COVID. So we had a lot of problems with outcome measures in our early trials in Fragile X, and this is just a slide to really show you the overwhelming amount of work that we have done to try to make outcome measures better in Fragile X over the past, say, 8 years or so. So we've taken different scales and factored them for Fragile X. We've created better ways of anchoring rating scales and CGIs. We've developed these videotape-based objective measures of communication, including expressive language sampling, the weighted communication scale, which is nonverbal and early verbal kids. Expressive language is obviously verbal kids, and the communication complexity scale that Nancy mentioned yesterday, we've been trying to use trying to tool up to use in trials of nonverbal kids with Fragile X. We've developed cognitive tests like the KITAP, and most importantly, the NIH Toolbox Cognitive Battery, which I'm going to talk about a little bit, created ways of looking at IQ so we can understand it in Fragile X. And then David Hessel's right now working on a behavior app for real-time behavior tracking. So a lot of outcome measure work. We also think that we need a biomarker that would be the holy grail that would predict cognitive improvement, so we don't have to do studies for 2 years to look at cognition. This could help us with target engagement, could help us with what drugs to move forward and what patients to select for the study based on the EEG response to a drug. We do have measures that translate. This is the gamma power that is the same in the mouse and the humans that we can translate directly, and the chirp response that again is the same at the same abnormality in Fragile X with the reduced chirp response, and we also see that in the mouse. Then we have measuring of processing of novel stimulus that's also abnormal on ERP. As well as eye tracking abnormalities. And we are trying right now to map these abnormalities that we see on things like EEG to specific functions, like mapping gamma power to anxiety and alpha power to focus and concentration, and some of these other habituation problems to sensory hypersensitivity, and the abnormal stimulus processing to language and learning. And so these are all, we need to make these connections so that these biomarkers can be useful to predict clinical outcomes. So expressive language sampling, we did a big validation study. Len Abaduto led this at these sites that are on the map. We used the Frog book, which everyone in the SLP world, I think, knows. And then we measured these specific kinds of language in the patient's language. We looked at Down syndrome, Fragile X, and autism. In the Fragile X sample, we had very good test-retest reproducibility for this test, and good construct validity for conversation and narration. And so this is a test that we now believe, especially for trials of patients age 12 and up, would be ready to be used in a clinical trial to measure language change. And the beauty of this is that we don't have to use 5 different versions of the cell for the PLS. We can actually use the same task with everyone. The Toolbox Cognitive Battery, David Hessel has been in charge of this project. Like I said, it has these different subtests in it where patients do different tasks. We did a big validation study in Fragile X, and we're now working on additional modifications of these tests. What we did was we modified the administration of the test so that someone with intellectual disability could do it more easily. And so we did see that most patients with Fragile X could do most of the tasks except for flanker, DCCS, and list sort, where we had lower percentage of patients that could do it. The test-retest reliability was variable, but best for the tasks that the patients could do best. And there was good convergent, discriminant, and ecological validity. And this is the Toolbox Cognitive Composite, which looks very close in terms of its prediction of the Stanford-Binet cognition score. And this is the bell curve that you get with the Toolbox. And then interestingly, the Toolbox was able to distinguish our groups a little bit, in that patients with Fragile X had problems with DCCS and flanker, which measure executive function and inhibition, and patients with Down syndrome were somewhat better at those. So we start to see cognitive profiles emerge on this cognitive test. And so this is something that we can put into place, particularly, again, for the older patients with Fragile X. This is very good as a performance-based cognitive measure. And then we also have worked with developing a way for parents to tell us what is the worst behavior. Again, the FDA didn't like the fact that we were just having parents tell us what was the worst behavior. So we went back to having them rate domains. That wasn't good. So more recently, we helped the parents put behaviors into domains, but then we personalize it with the most problematic behavior, and then the parents rate on a visual analog scale what's the most problematic behavior. I think I'm getting close to time, so I'm going to just shorten this, but leave it to say that we have a lot of specific abnormalities on ERP, event-related potentials, that we can pull out of the EEG of patients with Fragile X. We did a study at Rush that shows there's significant abnormal processing of novel stimuli, which is of interest to language processing, and that we get good reproducibility and a strong age effect in both typical and Fragile X patients, but Fragile X patients follow development on the ERP measure about like controls do, which actually was kind of surprising. We think that methylation may be important to study. This is another forward study where we can see the patients who are methylation mosaic, not pre-mutation size mosaic, but methylation mosaic, have higher Vineland scores. They are less likely to have autism, and they have a higher IQ. We know that FMRP correlates with IQ. And so the patients who are partially methylated may have different responses in trials. And in fact, the Zynerba CBD trial, where patients were randomized to Zynerba or placebo, did not show a statistically significant benefit in the entire group, but the patients who were fully methylated did actually show improvement in multiple different behaviors. On both the ABC, the Bent Behavior Checklist, as well as the Caregiver Global Impression of Change. And so we may need to incorporate methylation into our trials going forward to make sure we understand whether the fully methylated group is responding the same as the groups that are not fully methylated. So now I'm just going to show you real quickly, hopefully in 2 minutes, the study that we've done just recently is coming out. It will be coming out in Nature Medicine. This is a study where we go back to cyclic AMP, my original project in Fragile X, and there's a company called Tetra Discovery Partners that has a drug that normalizes cyclic AMP, and that actually reverses behaviors in the mouse. And so meanwhile, over the years, there's been work that showed cyclic AMP was was abnormal in the mouse brain and in stem cells, and we overexpressed FMR1 in neural cells and showed that cyclic AMP increases with more FMRP. And then this is just a whole plethora of experiments in the mouse that shows that you get normalization of cyclic AMP deficits in the mouse with this drug, normalization of spine length, and normalization of a number of behaviors. So we did a trial with Tetra, a very exploratory early trial where we did a crossover with a placebo and BPN 14770, which is their PDE4 inhibitor. And so, and then we crossed over and patients had placebo and drug, and we were looking kind of for carryover effects with this crossover. We enrolled this trial in 1.5 years and withstood COVID again to finish it. And we got the results actually literally the day before that baby that I showed you in the first slide's 30th birthday. So this was a 30-year trajectory in my life. But this study was actually a remarkable result where we showed that we looked at the 4 toolbox measures that were consistently doable by all the Fragile X patients as a pre-specified primary outcome, and showed significant change in cognition in toolbox in the treated group, significant for the crystallized measures and less significant for the other measures, but really trending toward improvement on drug and all the measures on toolbox. And this was really, for a 3-month trial, this was really kind of surprising. And this corresponded to rating of behaviors in the area of language and daily functioning by families as improved. Anxiety-related behaviors were not significantly improved, but these other behaviors that were things that families wrote down ahead of time, what they were rating, and things like food preparation, getting ready for work, taking the bus on your own, washing hair and shaving, bathing, showering, things like that in daily function, as well as things in the language domain like longer sentences, more varied topics, answering the question appropriately, conversation, asking for help, reduced self-talk, waiting for the right time to talk. These things improved on the drug relative to placebo. So this was really a striking change. And we did have a carryover effect in that, for instance, here, this is the patients that were on placebo initially actually improved in many cases after they went on drug in the second effect. And that had been seen in the mouse model also. So we really could only analyze the first phase of the study to give us the result. There was a trend toward improvement on the CGI, a significant improvement in go-no-go errors, and not as much in the other KITAP measures. And then some trends on the ABC. Remember, this is just 15 patients and controls in the initial part of the study. So we saw multiple areas of improvement, and we saw a P.06 trend toward improvement in the N1 amplitude that's too high in Fragile X, as well as directional movement toward improvement with more looking at the eyes and less looking at the nose and mouth on eye tracking. So this was overall a study that had a kind of remarkable outcome. And when we did a Cohen's d analysis, it suggested a very significant p-value for the improvement in cognition on toolbox and for the daily functioning and language measures that the parents pulled out. So, but of course, we need to get over that phase 3 bar, which has been the block in Fragile X. So we will be moving on into additional studies for phase 3 with this drug, but it has been very fulfilling to see a phase 2 trial like that of the drug that finally can target the mechanism that I discovered many years ago. And the reason that we couldn't have a drug to target that outcome before is that all of them have a lot of off-target toxicity in the body, and this one is really only active in the brain. So Fragile X, in conclusion, has been a pilot disorder, and we've learned a lot of lessons that are informing targeted treatment translation in Fragile X itself and other neurodevelopmental disorders. All of the work to develop better outcomes and development strategies we think is starting to pay off with improved trials and strategies that where we can better measure Fragile X outcomes, as indicated by maybe more success in some recent trials. We still have work to do at all levels, including the FDA. I think BPN 14770 is very promising for language, cognition, and function in Fragile X, and probably has the strongest result in a phase 2 trial we've seen yet. And hopefully 30 years of persistence will pay off with trials that work so that we can have treatments for all these patients with Fragile X. And that will really be the payoff when we have something come through that will actually target the underlying disease and improve the lives of all these patients. And this is just the list of, this is just all my acknowledgements. And unlike Nancy, who didn't do a list of acknowledgements because she couldn't get them all onto one slide, I'm sure I've missed people here. We've had funding from all different organizations. We have a great team here at Rush, and the families are truly our partners in our journey to develop treatments that will improve the quality of life in Fragile X. And that's all I'm going to say. And I'm sure I'm over by a little bit. Yeah. Okay. But I'm happy to take questions if there's time.
There are 3 questions in the Q&A area. Would you like me to just read them to you?
Sure.
So Dr. Brady asked you, we are seeing a slight decrease in aggression and self-injurious behavior as children become adolescents and young adults. This was a surprise to us. Do you see similar patterns?
I think we do see, it's different aggression is what we see. So what we see in the little kids is they're just hitting and they're aggressive because they kind of don't know how to respond to things, and they're upset about how things are going on, or they may be overstimulated, or they may be anxious, and this is how they're responding. Often in the adults, there's less minute-to-minute aggression, but then we have that one aggressive outburst that happens every 2 months that keeps them from having a job. So I don't know if it decreases as much as it just changes, but it might look like it decreases on a measure. And we do see patients get better control. Sometimes they have a bump in adolescence and then it goes down. But I would say that every patient is different in that regard. And we can see a pattern of getting better, or we can see a pattern of getting worse, kind of starting with adolescence.
There is another question. What are the usual side effects of medication for individuals with Fragile X? Are they a concern?
Well, so they vary depending on the study that the patient is in, obviously, but the side effects of typical drugs, we haven't had a huge amount of side effects. And yes, they are a concern because we will switch the patient off of a drug if they're having a significant side effect, or if they're in a trial, if they have too much side effect, they may have to come off of the drug. One of the issues is that Fragile X patients may not always be able to tell you they have side effects. And so sometimes the family will have to tell us, or sometimes we'll have to infer that there's a side effect. Things like weight are very easy for us to watch because we can measure it. But we do take extra caution to really ask about, if the patient's doing anything different, and to kind of dig into that when we're monitoring medications.
I just want to point out that Dr. Brady said, good job listing all your collaborators, and she thanked you for your response.
Yeah.
One more question. Would it be useful to have a non-human primate NHP model of FMR1 silencing? For example, primates have brain regions, I'm going to say this wrong, DIPFC, and even interneuron types that rodents do not.
Yeah.
Could also test gene therapies.
Yeah, it would be humongously useful to have that. We don't have it yet. I think there's a movement to develop that in China. We had several grants that we put into NIH to try to develop this at a primate facility in Seattle, but they never got funded. So it's been a little bit of a challenge to get to that, but I think it's easier to do in China. And so maybe at some point we will have that model. Obviously, all of these executive function, many of the things that we'd like to measure in Fragile X are very difficult to measure in a rodent. And it's not clear to me that rodent behavior actually translates directly to human behavior at all, really. I mean, I think we're much more better suited to using some of the electrophysiological measures and potentially biomarkers that we find in the animal model that may be more conserved and more closely recapitulate what's going on in the human than to try to expect that anxiety in the mouse works the same way as anxiety in a human.
Wonderful. Well, thank you.
Okay.
So very, very much. And I know we've gone a little over, but you still have some people in the room. I'm just going to mention that we are on our lunch break. And at this point, we have a separate Hangout, Google Hangout in the stage area that is open. Anybody can share their screen. So if you want to continue the discussion, I would encourage people to go to Stages and click on the Gatlinburg Hangout and to talk amongst yourselves there, or do what I'm going to do, which is go to my next meeting on Zoom. So thank you so much, Dr. Berry-Kravis, for your presentation. We really appreciate it.
All right, you're welcome. And sorry I went a little over. And
You're fine.
I will try to go to that Google thing if I can find it.
Yeah, so the stages area on the left side of the screen, and it should be right at the very top. Gatlinburg Hangout.
All right.
All right.
All right.
Have a good afternoon.